Hello everybody. On this lecture we are going to discuss one of the diseases which may affect the pregnant women during pregnancy, and these involving the renal and thyroid glands. To start with, we have to know the objective of these lectures. To start with, we have to know the normal physiological changes involving both the renal system and the thyroid gland, for which there is increased susceptibility for having certain diseases involving these two organs. And also we have to know the types of these diseases involving these two organs during pregnancy, what the clinical presentation that the patient may present it with, how I'm going to diagnose and treat these diseases. And also we have to know the fetal and maternal complication that the patient may have due to these diseases, and how I'm going to deal with them. To start with, we have to know the normal physiological changes involving or affecting the physiological of the renal system. As we know that the ureter and the renal calyceal system tend to be dilated. That's to say that the patient may present with hydroureter and hydronephrosis, and this should be remembered on ultrasound examination, because some of the patients during an ultrasound examination during pregnancy, they may have hydroureter and hydronephrosis, and we cannot say for sure whether this is a physiological or a pathological changes, because it may be due to the normal changes affecting the renal system during pregnancy. Actually, the hydroureter or dilatation of the ureter is mainly due to either mechanical or hormonal changes. The mechanical cause is mainly because of the pressure of the gravid uterus on the ureter, leading to dilatation of the ureter, and hormonal changes, which is the effect of the progesterone, which is a smooth muscle agents, and leading to relaxation of the ureter, and thus leading to dilatation of the ureter. At the same time, there will be an increase in the renal plasma flow and increase in the glomerular filtration rate, and all of these will lead to an increase in the excretion of a protein and increase in the creatinine clearance within the urine. And for this reason, usually the upper limit of the serum creatinine clearance and the proteinuria throughout the pregnancy, first of all, the creatinine clearance fills up to 65 micromole per liter, while the upper limit of proteinuria throughout the pregnancy tend to be increased up to 300 milligram per 24 hours. We have to keep in mind these changes while we are send the patient for laboratory investigation in the form of creatinine clearance or serum creatinine or albuminuria, in order to a proper assessment of the renal function during pregnancy. One of the most common abnormalities affecting the pregnant female during pregnancy is the urinary tract infection, and it is more common in a pregnancy, and this is mainly due to the physiological dilatation of the upper renal tract, which is mainly involving the renal pelvis and the ureter, as we say, either due to the mechanical cause or due to the hormonal effect. And this dilatation in the ureter may lead to stagnation of the urine within the ureter, and which enhance the multiplication of the microorganism and thus increase the risk of urinary tract infection. In addition, due to the effect of progesterone, this may cause relaxation of the vesico-ureteric reflex or increase the vesico-ureteric reflex, so that it will increase the risk of ascending infection from the bladder to the ureter, and thus increase the risk of ascending infection in the form of acute pyelonephritis. And we have three important infections. One of these are what is called as asymptomatic bacteriuria, and from its name, the asymptomatic bacteria, it means that the patient have a significant bacteriuria, but she have no symptom at all. And logical speaking, that the patient, if she have no symptom at all, but she have only bacteriuria, then there is no need to manage these patients or to treat them. But this is very wrong, because it has been found that about 40% or a half of these patients who has not been treated, if they are left without treatment, it may end up, or they may develop a symptomatic urinary tract infection in the form of either acute cystitis or pyelonephritis. Asymptomatic bacteriuria occur in about 4 to 7% of a pregnant lady. And again, if we are not treat these patients, about 40% of them, it will change to symptomatic urinary tract infection in form of cystitis, which is occur in or affect about 1% of pregnant ladies, or acute pyelonephritis, which is affect about 1 to 2% of pregnant ladies. Actually, there is certain predisposing factor for urinary tract infection, whether upper or lower urinary tract infection, and these are the previous history of urinary tract infection. Those female who have urinary tract infection prior to pregnancy, they are more vulnerable to have urinary tract infection during pregnancy, and even to recurrent attack of urinary tract infection during pregnancy. Also, those female who have certain systemic illness like diabetes mellitus, polycystic kidney, urinary tract calculi or renal stones, renal tract congenital malformation in the form of duplex kidney or ureter, neuropathic bladder, as in case of, for example, spina bifida or multiple sclerosis, and those female who have been kept on medication prior to pregnancy, as such as steroid or other immunosuppressive medication. Those female, they are more vulnerable or most likely to have urinary tract infection during pregnancy. The presentation of this female, as we say, that asymptomatic patient with asymptomatic bacteriuria, they have no symptom at all, but they have asymptomatic significant bacteriuria, and the asymptomatic bacteriuria, it means that the patient have no symptom at all, but they presented with some predisposing factor. And for that reason, any pregnant female during pregnancy, and they may have presented with some predisposing factor, which may increase their likelihood or their susceptibility to have urinary tract infection, then she should have an antenatal screening for urinary tract infection by having a clear cut midstream urine specimen for to be examined for any evidence of asymptomatic or significant bacteriuria. While those patients who have cystitis usually presented with some presentation, and these include urinary frequency, dysuria, hematuria, proteinuria, and even sometimes suprapubic pain or lower abdominal pain. While in case of pyelonephritis, the patient may present with more systemic manifestation in form of high-grade fever, loin pain, with or without an abdominal pain, may present with repeated vomiting, and sometimes with chills or rigor. Usually the diagnosis of urinary tract infection can be done either by the use of dipstick for presence or absence of albuminuria, and we have to have a midstream urine for analysis to detect the presence of bacteriuria, which means the presence of more than 100,000 organisms per 1 ml of urine or more. And also we have to have a midstream urine for culture and sensitivity, and this is usually should be repeated if it is shows non-significant results or it shows a mixed growth. So the midstream urine for culture and sensitivity can be repeated if shows no growth or non-significant growth, or mixed growth. The management of patient depends on the type of infection. If the patient have asymptomatic bacteriuria, then should be kept on 3-day courses of oral antibiotic. And this is again, as we say, that this is very important to prevent the patient to change to the symptomatic infection like acute pyelonephritis and its complication like preterm labor. While in case of acute cystitis, then we have to keep the patient on 1 week treatment with an oral antibiotic. In this patient, urine culture following treatment, it is mandatory in order to ensure complete eradication of the organism, because recurrent bacteriuria may occur in about 15% of women in pregnancy, and it may require a second course of antibiotic. Okay, فإذا 15% of patients may have a second or recurrence of infection and may require a second course of antibiotic. And ultrasound may be indicated in those patients who have 2 or more attacks of urinary tract infections or with positive urine culture, because the idea from the use of ultrasound in order to detect if there is any risk factor for the recurrent urinary tract infection like congenital malformation of the renal system or renal stone and so on. In case of pyelonephritis, then the antibiotic should be given for at least 10 to 14 days. Usually the antibiotic indicated to be given intravenously, especially for patients who have repeated vomiting or cannot tolerate to have an oral medication, and those who have pyrexia. An intravenous fluid should be given or may be required, especially for those patients who have repeated vomiting, and to correct the state of hydration for these patients. The renal function should be checked by take a blood sample for assessment of renal function in the form of blood urea and serum creatinine, and also the ultrasound should be done for this patient to exclude risk factor like hydronephrosis, renal stone, congenital abnormalities, and so on. The rule of the use of a prophylactic antibiotic, it is indicated when the patient have 2 or more attacks of urinary tract infections, or the urine culture and sensitivity shows positive culture. That's to say that the patient may be presented with recurrent urinary tract infection, or the ultrasound shows 1 or more of the risk factor for urinary tract infection. This is the treatment regimen for the urinary tract infection. If the patient kept on oral antibiotic, as in case of acute asymptomatic bacteriuria or acute cystitis, then we can use the amoxicillin in the dose of 500 milligram 3 times daily, or cefadroxil 500 milligram twice daily, or cephalexin 250 milligram 3 times daily. Nitrofurantoin can be given in a dose of 100 milligram 3 times daily, but should not be used in the 3rd trimester. While the intravenous antibiotic, it is indicated in case of acute pyelonephritis. The type of antibiotic is either in the form of cefuroxime in a dose of 750 milligram 3 times daily parenterally, or augmentin, which is a combination of the amoxicillin together with the glavulanic acid in dose of 1 gram 3 times daily. The gentamicin can be given in a dose of 2 to 5 milligram per kg body weight, divided 8 hourly. But this is usually, it is not the first choice or the first line of a treatment, or not, it is the treatment of choice for a patient with urinary tract infection during pregnancy, but it is only indicated for organism resistant to or for women who are allergic to penicillin or cephalosporin. That's to say that because the gentamicin is known to be ototoxic and nephrotoxic, so we can evaluate the cost and benefit from the use of gentamicin. If the cultural sensitivity shows that the organism is only sensitive for gentamicin, or the patient being found to be allergic to the use of other type of medications, so that the gentamicin is the only effective treatment, then we have to evaluate the benefit from using the gentamicin to eradicate the recurrent attack or the severe attack of acute pyelonephritis, and the risk of the likelihood of having some sort of malformation involving the fetus. This is how we are going to deal with these patients. So the gentamicin may be indicated in certain cases, but should be in certain circumstances we can use the gentamicin. Another subject that we are going to discuss is the renal impairment. And there is multiple causes for the renal impairment, which may include the reflux nephropathy, diabetes mellitus, certain diseases like systemic lupus erythematosus, glomerulonephritis, or even polycystic kidney disease. And we can classify the renal impairment into mild, moderate, and severe, and all this classification depends on the level of serum creatinine. However, the creatinine level, it depends on the muscle mass, so that the figure of the creatinine itself, since it is the creatinine depends on the muscle mass, so the level or the serum level of creatinine may represent a mild or moderate impairment in a female whose body weight, for example, is about 80 to 100 kilogram, but the same figure may represent a severe impairment in a female whose body weight around 50 kilogram. That's to say that the level of serum creatinine, since it is depend on the muscle mass, so the level of serum creatinine is in direct or in reverse direction to the body mass. The higher the body mass, so the serum level of creatinine, even if it is at higher level, it may indicate mild impairment in the renal function. Usually the presentation of patient with renal impairment, the most common presentation is the hypertension with albuminuria, with or without hematuria. And this is usually done in presented in early pregnancy, so that the renal or blood sample for assessment of renal function in early pregnancy or at booking visit is very important to be done prior or at booking visit in order as a baseline, first of all, for further assessment while the pregnancy is advanced, and also for assessment of the severity of the renal impairment in early pregnancy. To start with, we have to assess the effect of a pregnancy on renal impairment, and we can divide them into mild impairment or severe. The mild impairment, when the serum creatinine is less than 125 micromole per liter, and in these patients, usually the female can tolerate the pregnancy well, and there will be no renal deterioration in the renal function in this female. So if the serum creatinine is less than 125 micromole per liter, then the patient can tolerate the pregnancy well, and there is no deterioration in the renal function. While if the serum creatinine is more than 250 micromole per liter, which indicates that there is a severe renal impairment, then the patient at risk of or at increased risk of permanent loss of the function of the kidney during or even after pregnancy, and even sometimes may reach to an end stage of renal failure. These simply the effect of a pregnancy on the renal impairment. Then we will discuss the effect of renal impairment on the pregnancy. The effect of renal impairment on a pregnancy. To start with, the female who have renal impairment and they get pregnant, they are more vulnerable to have preeclampsia, intrauterine growth restriction, spontaneous and even sometimes iatrogenically induced preterm labor. They found that patients who have severe renal impairment with hypertension, they have less than 50% chance of having successful pregnancy because of severe and early onset of preeclampsia, or even associated with severe intrauterine growth restriction. And usually they found that spontaneous or even sometime premature delivery is justified in rapidly worsening renal function in order to avoid dialysis even in the absence of a preeclampsia. Okay? They found that patients who have severe renal impairment, they are more liable to have polyhydramnios during pregnancy. And with all the complications associated with polyhydramnios like malpresentation, cord prolapse, cord presentation, and increased risk of cesarean section, especially associated with malpresentations. And usually the polyhydramnios mainly due to fetal polyuria in response to the high osmotic load from increased maternal urea. Those females who have nephrotic syndrome and usually presented with heavy proteinuria, they are more vulnerable for have severe albuminuria, which may lead to associated risk of pulmonary edema and thrombosis, which also may be one of the risk factors that may occur in those females who have renal impairment and get pregnant. Now we will discuss the management of renal impairment in those females who have during pregnancy. If the patient have renal impairment and she wants to get pregnant, we have to concentrate on the importance of pre-pregnancy counseling and the requirement for multidisciplinary care, because it required consultation for the physician, for the nephrologist, for the obstetrician and others. So it is required also at the same time we have to explain to the pregnant to the woman who is going to get pregnant that it is a high risk group pregnancy, required multiple consultation during the antenatal period in order for early detection of any complication or any deterioration of the renal function during pregnancy. At the same time, it is very important to have documenting a baseline values, or what is called as a pre-pregnancy and early pregnancy investigation in the form of for creatinine, uric acid, albumin and protein. And this is usually as a baseline and also for further assessment of the renal function with advancement of a pregnancy. It is also important for tight control of even mild hypertension with the antihypertensive agents. The choice of is not different in women with renal disease. There is no difference in the use of antihypertensive in those females who have renal disease than those who have no renal disease. Also, those females who have already been kept on angiotensin converting enzyme inhibitors, then we have to discontinue these treatments prior to pregnancy or once the pregnancy is confirmed, because it is contraindicated to be used during pregnancy. Also, the patient who have been kept on diuretics prior to pregnancy, then we have to discontinue the diuretics unless if the patient have severe hypoalbuminemia or pulmonary edema, in which the diuretics may be indicated. So the diuretics can be given only if it is indicated, otherwise we have to stop use diuretics during pregnancy. Admission, it is usually indicated if the patient have worsening hypertension or increasing in the creatinine level, or there is a large increase in the proteinuria because of high risk of preeclampsia and with difficult diagnosis in the presence of increase in the blood pressure and proteinuria. So the admission is indicated in every patient who have worsening the renal function, or if the patient have increase in the albuminuria or difficulty in the controlling blood pressure and so on. Also, there is indication for the use of a prophylactic low dose of aspirin, 75 milligram per day, which is very important to decrease the risk of preeclampsia. Also, the patient should be kept on serial scans, an ultrasound scan for the fetal growth and liquor volume to exclude evidence of intrauterine growth restrictions in these females. And also we have to have serial hematology and biochemistry for proper assessment of the patient and renal function, assessment of the renal function to early detection of any deterioration in the renal function. And also in the postpartum period, we have to continue close monitoring the patients during this period, and we can repeat we can keep the patient on the angiotensin converting enzyme inhibitor after delivery, which is safely used in breastfeeding female. This is in general the management of patients who have renal impairment during, during and after pregnancy. Then we will discuss the thyroid disease. As you know, the thyroid gland have also certain physiological changes during pregnancy, and one of these changes is a slight increase in the size of the thyroid gland. Usually the thyroid gland tend to be increased in size during pregnancy, which is called as physiological goiter. And also the thyroid binding globulin is doubled in its production by the liver due to the effect of estrogen stimulation. So there will be an increase in both total T3 and T4. So the total T3 and T4 tend to be increased because of increase the function of the thyroid gland under the effect of estrogen, and also because of the increase in the thyroid binding globulin, which is produced by the liver, then there will be no significant increase in the T3 T4 level. Although there is an increase in the total T3 T4 under the effect of estrogen, which is stimulate the thyroid gland to increase the production of T3 T4, so the total T3 T4 tend to be elevated, but at the same time the thyroid binding globulin by the liver tend to be increased also, so the total T3 T4 remain unchanged during pregnancy. While the renal clearance of iodine tend to be increased because of an increase in the renal blood plasma flow and an increase in the glomerular filtration rate, and because of an increase in the consumption of the fetus to the iodine, then the patient tend to have reduction in the plasma inorganic iodine, and also this is also may increase the risk of having certain diseases involving the thyroid gland during pregnancy. This is the normal physiological changes involving the thyroid gland. One of the diseases involving the thyroid gland which may occur during pregnancy is the maternal hyperthyroidism. The incidence of maternal hyperthyroidism is 2 in every 1,000 1,000 pregnant ladies. The causes of maternal hyperthyroidism, the most common cause is the Graves' disease, which accounts for 90% of cases, which is an autoimmune disease with the presence of circulating thyroid-stimulating antibodies. In addition, there is toxic nodules, Hashimoto's thyroiditis, multiple nodular goiter, and very rarely trophoblastic disease, which is the H mole, or what is called high density foam mole, in which one of the presentation of high density foam mole is the thyrotoxicosis. Although it is rare, but it is one of the presentation of H mole is that the patient may present with sign and symptom of thyrotoxicosis. The diagnosis of maternal hyperthyroidism, it is very difficult in early pregnancy, depending on a clinical basis. Why? Because the symptom of hyperthyroidism, which is the palpitation, intolerance to cold, intolerance to heat or hot weather, it is similar to that of pregnancy itself. So it is clinically, it is very difficult. But in an uncontrolled hyperthyroidism, the patient may present it with cardiac arrhythmias, may be presented with repeated vomiting, diarrhea, abdominal pain and colic, and this is usually more obvious in severe uncontrolled form of maternal hyperthyroidism. The fetal complication of female patient with maternal hyperthyroidism, they are more vulnerable for intrauterine growth restriction, stillbirth, fetal tachycardia. On auscultation, the patient may present with fetal tachycardia, and also they may be more vulnerable for having a preterm labor. To lesser extent, may end up with abortion or congenital abnormalities of the fetus, and sometimes may end up with fetal thyrotoxicosis. The treatment of maternal hyperthyroidism is usually by the use of a drug therapy, and these idea or the aim of this treatment is just to maintain the maternal T3 and T4 within the normal upper limit, and the drugs of choice or the drugs that can be used is the carbimazole or propylthiouracil or even beta blockers like propranolol. Or the radioactive iodine, although this is one of the treatment that can be used, but it is contraindicated to be used during pregnancy since it may have radioactive agent, active effects, and it is maybe harmful to the fetus, and so that it is contraindicated to be used during pregnancy. Other abnormalities or disease which affect the thyroid gland is what is called as maternal hypothyroidism, and the incidence or it is affect about 9 of every 1,000 female pregnant female. And causes of maternal hypothyroidism, it is either iodine deficiency or over-treated hyperthyroidism. That's to say, female who have received over medication by anti-hyper like thyrouracil or others, or if the patient, for example, have thyrotoxicosis or have and she's been treated by thyroidectomy with excess excision of the thyroid gland and end up with hypothyroidism. The diagnosis is mainly depend on clinical manifestation, which is easy fatigability, cold intolerance, slurred speech. In female who are not pregnant, then they are usually present with oligomenorrhea or even amenorrhea. Sometimes it may be presented with menorrhagia in severe form of hypothyroidism and may be presented with infertility. To confirm the diagnosis, then we can send the patient for investigation in the form of thyroid function test, which shows that the free T3 and T4 seems to be decreased, while there will be an increase in the thyroid stimulating hormone. The fetal complication in female who have maternal hypothyroidism include congenital hypothyroidism and what is called as the cretinism of the newborn. Cretinism of the newborn. And this is usually occur if the cause is maternal iodine deficiency. In addition, the patient may have an abortion or preterm labor and even stillbirth. The treatment of patients with maternal hypothyroidism is mainly by restoring the thyroid-stimulating hormone to normal range by thyroxine replacement therapy. Yeah, that's to say by giving thyroxine either in a dose of 50 to 100 or even more than 100 microgram per day. I think this is the most important things you have to know regarding the renal and thyroid gland disorders affecting the pregnant lady. Thank you for your listening and goodbye. Thank you.